Hello, this is Miss Gibson. We are going to be going over electrolyte imbalances. This is chapter 13. So the first thing we're going to talk about is expected reference ranges. These will be given on the test, or there'll be a little chart if you have test questions for these. The reason that I'm going to put that on the test is you'll see several different ranges. Usually sodium and potassium stay the same, but calcium, magnesium, phosphorus, even your chloride will sometimes vary. So these ranges will be given if there's any test questions. This is just a cute little chart if you're a visual learner that goes over your reference ranges. It also tells you the role of each of those. I try to add different things because I am quite aware that each student learns differently. So your sodium imbalance, we know that it's a major electrolyte. It is a cation, which it just means that it has a positive charge. It is in the it moves into the intercellular fluid when you go into hyponatremia. We know that H2O flows in the same direction of sodium. We know that the kidneys regulate sodium with assistance from aldosterone, antidiuretic hormone, and this natriuretic peptide. The major area that we get sodium from is usually through the diet, and then we eliminate most of our sodium through the kidneys. So both of those things are very important to know. Hyponatremia, it's a net gain of water or loss of sodium that results in sodium levels less than 136. Some causes is decreased sodium intake, excessive intake of water. A lot of your patients that are MPO can end up with hyponatremia, fluid loss through the GI tract, extreme diaphoresis, which is just that extreme sweating, kidney disease. With the extreme sweating, these are the people that, in 100-degree weather and high humidity go for a 10-mile run and they don't replace their electrolytes. They're not drinking your Powerades or any kind of replacement fluids. So they're losing more than they're gaining. Your diuretics can also cause this, hyperlipidemia, hyperglycemia, any diagnoses that can decrease secretion of aldosterone can cause hyponatremia and, of course, your heart failure. There are certain medications that can decrease your sodium, your SSIRs, which is some psych meds, and your anticonvulsant. Some of your anticonvulsant meds can also decrease your sodium levels. If you go to page 260, there is a box that talks about hyponatremia. It's box 13.4. Here's another chart that you can use. Some signs and symptoms: mental status change, weakness, fatigue, abdominal cramps, nausea, vomiting, anorexia, muscle twitching, and postural hypotension. So you're going to make sure that you're doing your watching trends on your vitals. If they have this muscle weakness, you want to make sure that you are monitoring for respiratory distress. You want to put them on a monitor and watch their vitals closely. Nursing interventions, we want to encourage intake. Tomato juice, beef broth is also something that a lot of your facilities will have. You want to administer IV fluids as ordered, monitor I's and O's, and monitor vitals as well as their LOC. Here's your top fluids. You have isotonic, hypotonic, and hypertonic. One thing that you do want to remember is we don't give D5W to infants or patients with head injury because it can cause cerebral edema. We know that isotonic, that is the same as our intercellular fluids. Your hypotonic and hypertonic, sorry. Let's see. Now, hypernatremia, this is just an increased sodium. It causes a hypertonicity of the blood. It causes a shift of fluid out of the cells. Some of your causes, there's a long list. You can also see these on page 261, box 13.5. I'm not going to read through each of those. Just make sure that you know the main causes. A lot of times you'll see this with your kidney failure, your patients that have chronic renal failure, your patients that have to take steroids, and then also your Cushing disease or Cushing syndrome. I'm sorry. Definitely the patient will need to have some diet modifications. They'll be put on a low sodium or no sodium diet, just depending on what their comorbidities are and what has caused the hypernatremia. We know that a lot of the condiments like ketchup, mustard, even some of the butter has a high level of sodium in it. Any of your processed foods, any of your canned foods have a high amount of salt. And then, of course, you have your normal table salt. A lot of your seasonings, those types of things are going to have a high amount of sodium. Signs and symptoms, this is just a neat little chart that I found. Fever, flushed skin, irritability, increased fluid retention. You could have peripheral and pitting edema, decreased urine output. They're going to have dry mouth. You can also use the acronym SALT, skin flushed, agitation, low-grade fever, and thirst. And then here is just your main concern with hypernatremia. Of course, you're going to monitor your vital, any trends that you might have with that. Hyperthermia, are they tachy? Do they have orthostatic hypotension? You want to make sure that they're hooked up to a monitor where you can monitor them very closely. Neuromusculoskeletal, there will be restless, there will be some irritability, confusion, muscle twitching. There could also be, depending on how high their sodium levels are, they can have some respiratory compromise, decrease or even absent deep tendon response or reflex, seizures, and coma. Your GI signs and symptoms, of course, they'll be thirsty, they'll have dry mouth, nausea, vomiting. Sometimes you'll come across patients that'll have diarrhea. And then your cardiac, the reason that we monitor our patients' cardiac functions is with hypernatremia, they'll have decreased contractibility due to the sodium levels, which slows movement of calcium into the heart. And we know that calcium relaxes our muscles. I shouldn't say relaxes, it kind of softens everything. Relaxes, I guess, is probably a better word. I'm sorry. Nursing intervention, of course, you're just going to monitor labs. You're going to keep an eye on the potassium if you get an order for diuretics. Your good head-to-toe assessment, you want to make sure that you're doing good oral hygiene just because of the dry mucous membranes and dry mouth. You will want to make sure that you keep a IV access. So a lot of times if your patient has hypernatremia, dextrose 5% in 0.45% sodium chloride, it is actually a hypertonic solution, will be ordered, and this is because the glucose will help metabolize. The glucose metabolizes, so this becomes hypotonic. The preferred treatment, especially if you start to have cerebral edema, is 3% sodium chloride. This provides gradual reduction in blood sodium levels, and it, like I said, reduces the risk of cerebral edema. And going back to the fluids, if you go to your extra resources, that I have put several handouts on the different types of fluids. That way you have different avenues to study the fluids. So next we're going to go into hypokalemia. This is on page 262, box 13.6. Hypokalemia can be very dangerous. It can be life-threatening. Any changes in your potassium from that 3.5 to that 5 can cause cardiac issues, arrhythmias, and that can happen very quickly. Overuse of diuretics, steroids, even your digitalis, that can cause hypokalemia. The biggest reason that we see hypokalemia generally is your diuretics. Your increased aldosterone secretion, Cushing's syndrome, even vomiting and diarrhea, your GI upsets, prolonged GI suctioning, your meemaws and peepaws that feel like they need to have a bowel movement every day, so they overuse laxatives, which can create hypokalemia. The major source for potassium is our diet. So if you have a patient that is NPO, they can be at an increased risk for hypokalemia. Burns, any of your patients with kidney disease, they have a deficit in potassium absorption. And then heat-induced diaphoresis, excessive sweating. This is a neat chart that you can use to remember what happens with hypokalemia. Some of your signs and symptoms, they're going to have a decreased blood pressure, thready, weak pulse. You want to make sure that you're checking your orthostatic blood pressures. Neuro, they'll have altered mental status, anxiety, lethargy, in very severe cases, coma. Their ECGs, you'll see a flattened T wave, a prominent U wave, ST depression, and their PR intervals will be prolonged, which can be very dangerous. Their GI, they'll have hypoactive bowel sounds, nausea and vomiting, abdominal discomfort, and paralytic ileus, which just means that their bowel, there's not a whole lot happening within their GI tract. Muscular, there'll be weakness, and then respirations, they will have shallow breathing. So these people will end up being in the unit so that they can be closely monitored. With the nursing interventions, you have to be really careful and monitor for hyperkalemia if we overcorrect. So you could get an order for oral replacement. It could be that it's not significantly low, so their diet, you could just encourage foods high in potassium. You're going to monitor their urine output. Always, always, always monitor their cardiac functions, their level of consciousness. They will be on fall precautions just because of that orthostatic hypotension. Foods high in potassium are dried fruits, cantaloupe, bananas, some of your salt substitutes, avocados, things like that. Your max recommended potassium dose per IV is a rate of 10 milliequivalents with a concentration of no more than 1 milliequivalent of potassium per 10 mLs of solution. You want to make sure that when you are given potassium that you are following your doctor's order and that you're also monitoring for phlebitis. If for some reason you are given potassium and the IV infiltrates, that becomes very painful very quickly and can cause that phlebitis. Potassium, if you don't dilute it and run it with normal saline, which is the only thing that you should be running with potassium, it can be very painful for your patients. So make sure that you're doing your close observation of your patients, and if they complain of pain, you may have to increase your rate that you're pushing your normal saline, which makes it a little bit more tolerable, but it is very painful going in. Especially if you just have a peripheral IV. Now your central lines, even central lines, ports, PICC lines, things like that, that is the recommended intervention for giving potassium. But if you only have peripheral, you want to make sure that you're giving it with normal saline to help decrease that pain. Hyperkalemia, some of the causes is decrease in renin and aldosterone, which you'll see in your chronic kidney failure patients. Increased use of your salt substitutes, just like we were talking about with hypokalemia. If you encourage your patient to try to increase their intake of potassium and they start using some of these salt substitutes, they could very quickly go from hypokalemia to hyper. ACE inhibitors can increase the potassium. Your potassium sparing diuretics, that just means that your body is holding on to that potassium. Potassium replacements, red blood cell transfusions, adrenal insufficiency, DKA, tissue damage, and hyperuricemia. With your tissue damage, this is just because of an increased risk, increased stress on the body. such as sepsis, trauma, surgery, fever, myocardial infarction, anything like that can cause hypernatremia that sends the body into stress mode. So things are moving from one compartment into another compartment. Signs and symptoms, you're always going to monitor vital sign trends. They will be hooked up to a monitor so that you can monitor for PVCs, VFib, peak T waves, urea, so sorry, which just means an increased urine output. Gracious alive. With your GI tract, it is opposite of hypo. You will have an increased motility, diarrhea, hyperactive bowel sounds, where with hypo, you were actually at risk for paralytic ileus. So very, very important. Potassium levels in acidosis, when your potassium is going up, you will generally be moving. Potassium goes up in acidosis, so that's really important. You want to monitor your lab values and make sure that they don't end up acidotic. Nursing interventions, the biggest thing is monitoring your cardiac rhythm. That's the most important thing. You're going to monitor your I's and O's, maintain IV access. Generally, with hyperkalemia, it is due to medications like your loop diuretics that increase the depletion of potassium. You can give IV insulin and glucose, which lowers potassium by causing that shift into the intercellular space. To permit the movement of potassium from the extracellular fluid to intercellular fluid, you may get an order to administer fluids with dextrose or even regular insulin. You may also get an order for the administration of bicarb, which we know that your sodium bicarb reverses acidosis. Let's see, this is just a chart that talks about the calcium-phosphorus relationship. When your calcium is up, phosphorus will be low. When calcium is low, phosphorus will be up. It has an inverse relationship. Hypercalcemia, some of the causes is always with your electrolytes, just inadequate intake. If you have a lot of diarrhea, not enough vitamin D intake, end-stage kidney disease can cause hypocalcemia, alkalosis, pancreatitis, immobility can also cause hypocalcemia. If you have a patient that has lactulose intolerance or a malabsorption issue like your celiac disease, Crohn's disease, IBF, your pancreatic insufficiencies, any of those diagnoses that can cause hypocalcemia. Some of the medications that should key you in to monitor for hypocalcemia is your medicines and that might be given for increased uric acid levels, your colchicines, your irritant laxatives, neomycin, tetracycline. Some of your antacids can cause hypocalcemia. There's also some weight loss medications that could cause that. With the weight loss medications, it causes fatty stools or oily stools that can actually block those diet pills. If they're a lipase inhibitor, they block the absorption of fat. So that can cause it's steatorrhea, sorry, which is just fatty stool from those weight loss medications. 99% of your calcium are found in the bones and teeth. 1% is actually found in soft tissue and extracellular fluid. Some of your signs and symptoms, tetany, which is the most common finding. Tetany is caused by neuroexcitability. Tetany is caused by neural excitability, spontaneous discharge from both the sensory and motor fibers of your peripheral nerves. You could also have some paresthesia, which is just tingling or numbness. It kind of feels like your patients will explain it as pins and needles. You can have muscle spasms, which a lot of our older patients will call it Charlie horses. Other signs and symptoms could be prolonged QT intervals, your torsades de pointes, which is a dysrhythmia, decreased heart rate due to decreased myocardial contractibility, and then don't forget your two different signs. This torsades de pointes, this is a fast heart rhythm, and if it's not corrected immediately, it can lead to death. The Chavoskit sign, this is a tapping on the facial nerves, kind of on the jaw area, and it causes facial twitching. I always mispronounce this, but this sign is where you use the blood pressure cuff, and once you tighten it up, it causes that hand and finger spasms that kind of your fingers kind of come together as the muscle spasm. My goodness, you put the blood pressure cuff on and it causes your hand and fingers to kind of come together in a spasm. Let's see, your nursing interventions for hypokalemia. Of course, you're going to give oral or IV calcium. You're always going to implement seizure precautions as well as fall precaution. You want to keep the room as quiet and cool as possible. You don't want any overstimulation. You're going to do that good education on increasing their calcium in their diet. Always monitor their lab values. As I've said prior, with these extra electrolyte imbalances, it's very easy to overcorrect. So if they're hypo, they very quickly can become hyper. Your dairy products, canned salmon, sardines, things like that are high in calcium. Some of the medications that might be ordered, I don't know why I can't speak, is calcium glutamate, even calcium chloride, which you won't see that a whole lot because if your IV was to infiltrate while giving that calcium chloride, it can cause tissue damage. But you will see calcium glutamate ordered frequently. Here's a picture of each of those signs. With this one, you're going to place the blood pressure cuff on the arm. You're going to inflate to about 20 above their normal systolic blood pressure. Hold it for about 3 to 5 minutes. This increases the irritability of the nerves, and a flexion of the wrist in metacarpal joints can be observed with extension of an adduction of the thumb. So it's like a carpal spasm. As I said, the fingers kind of come together. This one is actually more specific to hypocalcemia than this sign. This is a video of them doing the Chavosky sign. Hypercalcemia, you're going to see this with increased intake of calcium as well as increased intake of vitamin D. You'll see hypercalcemia a lot in chronic kidney disease patients, cancer patients, and immobility patients. With the cancers, you'll see any of your patients, if you work on an oncology floor, your lung, kidney patients, your multiple myeloma patients, breast cancer, and leukemia are at a increased risk of hypercalcemia. In dehydration with your chronic kidney patients, the kidneys can't secrete the calcium, so you become hyper with that. This is a cute little chart for signs of hypercalcemia. We know with the stones, most of your kidney stones are made of calcium. A lot of patients will come in with chronic kidney stone problems, and it's because their body is producing an overabundance of calcium. Some signs and symptoms, cardiovascular, they'll have poor perfusion and a shortened QT interval. They are at increased risk of blood clots, confusion. They'll have decreased peristalsis, which is just hypoactive bowel sounds, and like I just mentioned, risk for kidney stone. They'll have, with mild cases of hypercalcemia, they will have an increased heart rate and BP. As this hypercalcemia continues, if it's not corrected, the heart rate will begin to slow because it depresses the electrical conduction of the heart. So the heart rate with prolonged hypercalcemia will begin to slow. With the GI issues, you'll have constipation. I don't know why I cannot speak. Please forgive me. With GI issues, you will have constipation, anorexia, nausea, vomiting, and they will complain of stomach pain just because of abdominal distension. Nursing interventions, drug therapy, they'll always be on a cardiac monitor. If they are on a, if they're got an order for lactic ringers, you will stop that. You'll stop any antacids, any thiazide. If they have been ordered thiazide, generally the doctor will want that stopped and replaced with Lasix. The IV medication of choice will be normal saline. We know that sodium increases excretion of calcium. So you want to make sure that you're keeping IV access. That way, when the normal saline is ordered, if they're not already on it, the sodium will help excrete calcium. All right, so next is hypomagnesia. This is anything under that 1.3. The biggest cause of hypomagnesium is malnutrition, starvation. You'll also see it in celiac and Crohn's disease, as well as any patient that has uncontrolled diabetes. You'll also see it in your chronic alcohol users. Magnesium promotes the regulation of calcium and potassium. It works with calcium for proper functioning of excitable cells. So magnesium and calcium can be released. It's essential for integrity of nervous tissue, skeletal muscle, and cardiac function. There's a chart on page 268. Magnesium is the second most abundant intercellular ion. 60% is found in the bone, 39% found in muscle and soft tissue, and 1% found in extracellular fluid. Some medications that you might expect is proton pump inhibitors like your omeprazole and your Protonics. You may also be ordered diuretics. No, I'm sorry, I misspoke there. Please forgive me. These are medicines that can cause hypomagnesemia. Your proton pump inhibitors, diuretics, and there's also a couple chemo drugs that can cause hypomagnesemia. Our major source is from our diet, whole grains, fruits, veggies, and fish. Here's another chart. Signs and symptoms, you'll definitely have intestinal changes, neuromuscular changes. There'll be an increased impulse transmission and some dysrhythmia, so they will need to be hooked up to a monitor. We know that hypomagnesemia is very dangerous because when magnesium is low, so is potassium. We also know that hypomagnesemia can occur with hypocalcemia. So, anytime your magnesium is low, other electrolytes will be low. So, it can be very dangerous. It can also cause tetany, which is just that involuntary contraction of muscles, cramps, spasms, whatever you want to call it, but you'll see tetany with this as well as hypocalcemia. Your nursing interventions, of course, we just want to replace, so drug therapy is ordered. Some medications that might be ordered for this is your loop diuretics, as well as your osmotic diuretics. If the patient is on phosphorus, that should be discontinued. Your hypermagnesium, this increased magnesium intake, which is the most popular cause. IV magnesium replacement, as I will continue to say, if you're hypo and you overcorrect, you'll very quickly become hyper. And decreased kidney excretion. Your patients that have kidney disease, they will experience a lot of these electrolyte imbalances just because the kidneys aren't functioning properly. You could also have hypermagnesium if your patients overuse magnesium containing antacids or laxatives. So, a lot of times when we have patients that come in and we're doing their admission, they forget to tell you about their Tums or their laxatives. They forget to tell you about vitamins or any over-the-counter medication. So that's a very important step with the admission process, is that you ask not only about prescribed medication, but also if they're trying to take anything over the counter. With hypermagnesium, we know that they're in an increased risk for cardiac arrest due to bradycardia. With the central nervous system, changes result from depression of nerve impulse transmissions. The voluntary skeletal muscle contractions become progressively weaker and finally stop. So make sure that you're monitoring for respiratory distress. This is a really neat video from Simple Nursing. He uses this little sheriff, which is a very easy way to remember. If I haven't already discussed it, simple nursing, this gentleman goes above and beyond to help with ways to remember different nursing definitions, interventions, signs, and symptoms. If you haven't looked him up, just go to YouTube or even Google and type in simple nursing. He has several videos that are wonderful. I actually used it when I was working on my ADN several years ago, so highly recommend him. Some of your nursing interventions, of course, you're going to discontinue magnesium meds. You're going to give the high ceiling loop diuretics, which is Lasix, is ordered. Always, always, always monitor cardiac and lab values. Giving calcium may reverse the cardiac effects of hypermagnesium. It just depends on what the cause was. So you may get an order for like calcium glutamate to help with the hypermagnesium, but it just depends on the cause. So with your phosphatate, this is usually caused from just an insufficient dietary intake, excessive urinary excretion, and then your phosphorus binding and acids. Our main source comes from our diet, so things such as beef, pork, fish, liver, poultry, whole grains. 90% of our phosphorus is excreted from the kidneys. 70 to 80% are found in bones and teeth, 10% in muscle, and the other 10% in nervous tissue. It does have an inverse relationship with calcium. Increased calcium promotes phosphorus excretion because the phosphorus and calcium have an inverse relationship. It supports and maintains strong bones and teeth. It's also a buffer to help regulate acid-base balance, and it assists in normal nerve and muscle activity. So you have to kind of know what each electrolyte does. That way you can critically think what some causes may be or what some interventions may be as well. In other words, we know here that it affects the nervous system. So what might you look for? It's excreted by the kidneys. Well, if your patient has chronic kidney disease, will they have hypo or hyper? Those are the type of things that you want to look at. Signs and symptoms: confusion, numbness, seizures, muscle weakness, incoordination. Remember, it affects your nervous system. Changes in your red blood counts, decreased oxygen carrying capacity can cause tissue anoxia. But mostly with hypophosphatate, you will see neuro changes. Your nursing interventions, you're just going to monitor your patient very closely. Usually there'll be an order for IV sodium phosphate or IV potassium phosphate if it is severe. Hypophosphatemia is usually not life-threatening, and it's usually caused from other electrolyte imbalances. Hyper, usually it is your renal failure patients. Phosphorus is excreted through your kidneys, and if your kidneys are not working, then your body can't get rid of it. This is another video that talks about hyperphosphatemia. Signs and symptoms, most of your signs and symptoms of hyper is going to be related to decreased calcium. We know if calcium is low, your phosphorus is going to be high. If phosphorus is low, your calcium is going to be, let me repeat that. If phosphorus is high, your calcium is going to be low. If calcium is high, your phosphorus will be low. So with hyper, it's all going to be related to that decreased calcium, which causes a lot of neuro issues, that tetany, numbness, tingling around the mouth, anorexia, severe nausea, vomiting, and then your increased deep tendon reflexes. My heavens, I cannot speak today. Nursing interventions, always, cardiac functions, vitals, labs. You're always going to monitor your renal functions. Just an idea of, you may be given IV calcium. Usually this will be ordered 30 minutes before breakfast and at bedtime. You might get an order for calcium glutamate IV or vitamin D supplements like calcitrol. Chloride, linked to sodium. It can be combined with sodium. We get most of it through our diet. It is excreted through our kidneys. Chloride also regulates acid-base balances, and it regulates osmotic pressure between your intercellular fluid and your extracellular fluid. This is a video on chloride. Your chloride imbalances, hypo occurs with hyponatremia. Hyperchloremia is seen when your bicarb falls because chloride attempts to compensate to keep equal number of anions and cations in your extracellular fluid. Just know that with any of your chloride imbalances, they both rarely occur alone. They are happening, your chloride's either going to be high or low because of other imbalances. Your bicarb is found in your extracellular fluid. The major function of your bicarb is the regulation of acid-base balance. If you have a patient that comes in for acidosis, you will give sodium bicarb. It's the major chemical base buffer in the body. It acts to neutralize acids in the body. So it's very, very important for acidosis. The kidneys regulate the amount of bicarb retained or excreted. So anytime that you see kidneys regulate the amount of whatever electrolyte, you know that a major concern is with our kidney failure or our chronic kidney failure, or even your acute renal failure patients are going to be at an increased risk for these imbalances. This is another video for your chloride. And this is my babies once again. These are Belgian draft horses. They are about 6.5 to 7 feet tall. This one is over 6 foot tall. They are precious. You can walk out in the field and they will come right up to you, let you rub them. They'll lay their head on your shoulder. They're just precious. So this is the end of Electrolyte Imbalance. If you have any questions, if I have confused you, or if I have misspoken, please email me. We'll figure it out together. I'm always available through email. If you would like to come in and meet, just email me and we will get a schedule worked out. Thank you so much.